for this discussion on a new set of drugs, which are now become available to all of us in our country. So I just wanted to know, is anybody used Nivo-Ipi in practice today? I mean, in the first line maybe. Is there a show of hands amongst the panelists? Yeah, Ashish? Yeah. Okay, great.
We have a trial running.
Yeah.
Fortunate to use
You're running a trial.
lot of experience.
So it's in the trial, but not in the day-to-day practice.
Day-to-day I've used few, but
okay, you have used. Okay. Yeah, because as I see here, I mean, in the approvals for Nivo-Ipi, so there are a lot of competing approvals as well, which incorporate the immune checkpoint inhibitors. So, we are actually spoiled for choice today when it comes to, using a dual, immune checkpoint inhibitor combination. So I think with this discussion, we might switch or we might not, because as I said, the options are there. So the idea is to dissect out the role of Nivo-Ipi in, I think we have 3 cancer types and see where it can be placed. And as, been discussing and Amish said, so this basically, lets you use a second alternative which would not used, in the first line. So for example, we're going to discuss the first situation, which is the kidney cancer. And that's where, see the NCCN guidelines, where in the first line, you have in the poor and intermediate subgroup of metastatic RCC, the approval there, and where actually most of the patients, belong to. But then, I mean, you have all these approvals. So why do we choose one over the other? I mean, I don't know. I really don't know. And why not Nivo-Ipi? So anyway, so the point is to, bring the Nivo-Ipi discussion to the fore so that, we can maybe go back and start using it. So just coming to the trial, so this is, from Moitzer et al., and this was published in NEJM, and there where they used Nivo 3 milligram per kilogram plus Ipilimumab. The first one was 3 weekly, and so any comment on this study design, or rather the drugs used? Ashish, you've been using it, so in kidney cancer. So I got to understand something which I didn't know before. So
this is the sort of a standard design, and in only in the EP there is a differential dosing.
Right.
We've got a lot of some of the studies wherein EP is used as 1 mg per kg every 6 weeks, whereas this is the conventional dosing, and this is what probably I have used in the first line RCC setup. So number one, as far as the experience of the toxicity is concerned, fairly well tolerated as against the experience that we have had. But the only concern which we have had is the long-term continuation of Nivolumab.
Right.
We have had immunotherapy-related issues, and we had to discontinue in some of our patients. Secondly, Sunitinib at the dosages which has been given is not the typical dosages that we practice in our clinical studies. So that's one of the concerns that we have as far as this particular study is concerned. But for a intermediate or a unfavorable risk group of patients, I think we need something much more than Sunitinib. The curves are quite disparate. The numbers are quite interesting, and one may think of using Nivo-Ipi as a first-line treatment for a
Sachin, your thoughts? So both the subgroups are getting Nivo-Ipi, right? So that's what I got to know from this study. When I really looked into it in detail, so both the groups got Nivo-Ipi, and after 4 cycles, in one subgroup, Nivo was continued, and in the other, only Sunitinib was given. So actually, both the subgroups are getting.
No, it's not that way, sir. It's not
yes,
that
sir. Way. Yes, sir.
No, it's not that way.
Yes, sir.
It was only Sunitinib.
No, sir.
Yes.
So read the patients with untreated RCC were randomized to receive Nivo and Ipi for 4 cycles. Then either Nivo monotherapy or Sunitinib was given on a daily. No.
Yes, sir. It is only Sunitinib. It is only Sunitinib in the control arm.
And anybody who has, sort of used this, yes, Dr. Banavali, I don't know.
For sure. That all is for the entire sentence.
I'm not sure.
Nivo continues versus Sunitinib.
Yeah.
So only Sunitinib.
Yes.
Okay. Okay. So that was one understanding which I thought was perhaps missing. So let's come to the curves. So once the large number of patients. So are you happy with this intent to treat situation? All risk intention to treat.
Yes, sir. Seems interesting, sir. With overall survival.
So with the hazard ratio of 0.72 and so can I have a comment from Dr. Prabhat?
Yeah, this looks quite impressive in a all risk intention to treat population itself. We are getting a OS benefit, which is statistically significant.
Okay, so let's go to the subgroup analysis, which was, much more, which was differentiating between the favorable risk and the intermediate and the poor risk category. So is that again okay, Sachin? What do you think?
This definitely gives us a clear idea about our selection of patients for Nivo plus EP. Favorable risk, obviously no for this combination, but then for poor risk and intermediate risk, this is possibly a better choice than single agent TKI.
So you agree with the approvals which have been given by the, NCC and other guidelines on the basis of these curves, because this has, 420 odd patients in each arm. Yeah, Ashish?
So with the background of this data, how would you pitch Nivo EP versus TKI plus?
Yeah, we'll come to that. So that I think that's perhaps the last part of the. So I think based on this data, we are happy for using Nivo EP in the intermediate and the high risk category patients. Okay, so
Why is it not working?
why?
Why is it not working?
So
It's working.
It's working. The tail.
no, in the favorable group. He's asking in the favorable group.
Why in the intermediate poor it's doing so well, but in the favorable, the thing is it's just.
So what is there in the biology of kidney cancer which is preventing the Nivo EP to work in the favorable category?
As we can see, the curves have crossed over, and maybe over a period, as we were talking, that in immunotherapy, this is a tail which would matter.
Right, but this is, but this is,
started falling.
probability at 5 years is, they're not sort of separating, they're not separating. Yeah. Ashish, any thoughts?
Honestly,
Anybody here? So what I think is, because as you've seen in the favorable category, so I think the angiogenesis is the main key in these patients who are favorable risk, as compared to the immune checkpoint inhibition, which is more effective in the intermediate and the high risk category. So that is supposed to be the difference, why the angiogenesis TKIs are working in the favorable risk. No, but then the immune issues take over more than the angiogenesis issues as compared to in the unfavorable category. So that is the, biological explanation to why patients are perhaps, equally responding. The curves are not bad here for Nivo EP. They're overlapping, as you see. And I'll show you the conditional survival in the next set of the slides. And then that is where you will see that the immune checkpoint inhibitors are not really bad there also. But I think why the TKI is working as good as immune checkpoint is because angiogenesis has a key role in at least this favorable group of patients. Okay, so these are, these are the same curves which are there for Nivo EP as overall survival, where you see PFS, OS, and the duration of response in the intermediate risk category. So I think this is just to summarize that. So now, I think this is again, let's go to the conditional survival, which is more important now. So this is the overall survival for the, you can see here for the favorable risk. Now you see the duration of response, to answer your question there. So the duration of response, anybody wants to comment on Nivo EP versus the Sunitinib? Dr. Prabhat? You see the duration of response is, at almost 5 years is 58% versus 21% with Sunitinib.
So it's almost twice our duration.
Correct.
And I think when we achieve such a landmark survival, we need to look beyond that. And that's when conditional survival comes.
Correct. Because initially for 24 months, almost the curves are, almost parallel to each other in terms of duration of response. They start separating towards, after 2 years. So why is that? Maybe Dr. Raja, yeah.
like to answer you, but I have a question. This particular study more exemplified the tail of the flat tail of the curve phenomenon. Well exemplified. My trouble is how do I factor in the tail of curve phenomenon and that proportion to a patient when we are trying to counsel them upfront? There is a real tail of curve, we see that, but when we see the 10 patients, 20 patients, how do we really take that to them, the tail of curve phenomenon?
Tail of curve phenomenon.
Yeah, the flat tail goes on, long survival.
Long term.
This CheckMate 214 is very special for that.
Right. So I think when we discuss the conditional survival in the next part of this discussion, maybe we'll get some answers there. That are there any differentiating features to discuss that? But I think we just move on to this.
Sir, can I?
Yeah.
Can we go back to the last slide, sir?
Yeah.
Sir, looks like the PFS looks like it is doing something about it. The immunotherapy. Is it that in Sunitinib arm the salvage by immunotherapy?
Salvage by immunotherapy
It has been far better because you get more chance for it to work, because this low risk group, RCC, they give you time, they don't deteriorate so fast.
Anybody has any idea on the paper as to what percentage of patients from Sunitinib switch to the Nivo-Ipi or Nivolumab for that matter?
30%. 30%.
So 30%, that is what the answer is. Will that be responsible for, this kind of a separation of curve beyond 1 to 2 years? It is for all of you to discuss. So this was the forest plot for discussing the, Nivo-Ipi versus Sunitinib. And if you were to see PDL1 expression towards the, bottom of this slide, both the subgroups are sort of benefiting. So are there any differentiating features there? Nephrectomy versus no nephrectomy doesn't really matter here. So, this also brings me to a point that these kind of combinations of, Nivo-Ipi or for that matter, immune checkpoint inhibitor with a TKI, like the Carmina study, although you don't have a study there, but they can be used in patients with metastatic disease. So these perhaps are more potent than as compared to Sunitinib. So any comment there regarding, because we are seeing patients with metastatic disease and we always have a debate, should we do nephrectomy, the surgeons want to do it, or should we go for systemic therapy? And now that we have these immune checkpoint inhibitors which are better perhaps than the Sunitinib or the other drug. So any thoughts on using upfront, immune checkpoint inhibitor combination in a patient with metastatic disease? Dr. Sachin?
Obviously, what's most attractive about immunotherapy is the duration of response and the long-term survival. But the concern with monotherapy is obviously that the response rates and the disease control rates are low. When we are using combination, possibly we are trying to overcome that particular drawback of a single agent. So if you are able to use the combination upfront and we are able to achieve both the long-term duration of response as well as the so-called drawback of low disease control rate, I think that's a better.
Right. So I think with this combination which we're getting more responses and even complete responses. So that adds us to confidence to use, these drugs than as compared to Sunitinib. Yeah.
So your question is that should we do away with nephrectomy?
Yes. Yeah.
I think Dr. Raja sir had in one of the presentations compared all the category 1 of MRCC. All you say, Pepro, XE,
Yeah.
and 88 to 89% in each of these had a nephrectomy done. So the question is that, sir, we don't have the data, and here also
Right.
if you see, it's a very small number of patients who had not had nephrectomy.
Yeah.
So I think the maximum amount of data what we have is with nephrectomy. So to do away with nephrectomy right now, I don't think we have enough data for that, sir.
But I think with the Carmina data available, I am reasonably convinced for using these, immune checkpoint inhibitors, especially,
This is a very important question because ultimately urologists, they do the nephrectomy and then send the patient to us. But suppose assuming the patient comes to us, it's a very important question whether to do nephrectomy or not.
All right, that's, I think, a little different debate, but then, I don't think you are wrong in doing the immune checkpoint inhibitor treatment upfront than as compared to nephrectomy.
Carmina study were from
this trial and then we did have some role. In the study, without immunotherapy,
Not only didn't improve outcome, if you take intermediate and poor risk group, there is a potential harm there. And again, that's subgroup, but enough to caution people that doing nephrectomy to every patient is an issue. I do understand in trial you get many kinds of patients. As Senthil was saying, you get entry of patients but not receiving many of those routine treatment. But that should not be the way of interpreting it.
Right.
So, except for low risk group at our center, if the patient is asymptomatic, usually we don't go ahead with nephrectomy.
Okay. So I think let's move on. So now coming to the conditional survival and long-term efficacy with Nivo-IP, again, the same data has been analyzed by Moderator et al. And got published in April 2022. So any thoughts on what is conditional survival? And Ashish, I'm sure you've gone through the paper. So conditional survival is derived from the concept of conditional probability could provide more relevant prognostic information at each follow-up period. So yeah, I'll show you the next slides. Yeah.
Conditional survival actually gives us what happens in the real world situation, proximal to the real world situation, and that actually can make us make a clinical decision for an individual patient. So I believe that it's a very, very attractive concept, and probably it gives a closer answers to what we could do and tell our patient as far as the treatment impact is concerned.
Right, so as it says here, the probability of surviving an additional number of years, given that the patient has already survived a certain number of years, is the conditional overall survival. So, if somebody has, so it's different now. You see, earlier, as I said, somebody is on chemotherapy, somebody is on, targeted drugs, the curves were, dropping. Nobody was living at 2, 3, 4 years maximum. But now, with the use of immune checkpoint inhibitors, we understand that 20-30% patients are going to live beyond 3, 4, 5 years. So, a person wants to know if he has lived for 2 years, will he be living for another 5 years, or will he be living for another 1 year? So, and what are the factors associated with that? So that is what the conditional, so for example here, the estimate for surviving through year 1 is say 0.95 if 95 out of 100 are surviving. And if one does survive through 1 year, the conditional probability of then surviving through year 2 is 0.8913 if 82 out of 92 are surviving. So the estimated probability for surviving both year 1 and 2 is therefore 0.8467. So that is the way they are calculating the conditional probability of survival. So this would decline over a period of time in most of the cancer patients, metastatic disease. That perhaps is not happening when you're treating patients with immune checkpoint inhibitors who are surviving at 2 years, 3 years, 4 years. That's what you will see. So that is the important point here for looking at conditional survival probability. So in this study, what they did was the probability of remaining alive or having PFS or in response 2 years beyond the landmark time points of 2 years and 3 years were analyzed. Okay. So this is the conditional overall survival. So now you see this is the intent to treat population, and you look at the intermediate and the poor risk population, and you look at the favorable risk population. So now coming to the favorable risk. So, you see that the curve is actually getting better for the Nivo-IP even after 2-3 years. So now you see the curves are actually almost parallel. So it is not that there is a decline happening. So would you like to comment on this?
Proves the tissue agnostic behavior of Nivo-IP combination in this setting. Probably some of this favorable risk group of patients could even be benefited, and we can make them even better with the use of Nivo-IP combination. But again, this is just a conditional survival aspect of it.
And mind you, these patients were continuing on treatment. So, because only patients who stopped treatment were who could not tolerate or otherwise, or had some side effects. So it's not that they were stopping at 2 years. So that is the other issue with these drugs, which you need to continue. So this is the conditional overall survival, which is actually not declining after 2-3 years. So if at all, if you look at the favorable risk, with the Nivo-IP, it's getting better. So, but if you look at the intermediate and poor risk, it is actually getting better. So that is not there with the chemotherapy drugs or with the targeted drugs, sir.
So I just wanted to clarify that
Conditional survival is very much like life expectancy at birth versus life expectancy at 50 years or at 10 years. So we know that a large proportion of deaths in a country like India are due to infant and early childhood mortality. So if you exclude those and then put the conditionals, take the subsequent survival only for those children who have survived the first 10 years, they'll be better than if you take it at time point 0. So what this curve actually says is that the probability of living 2 more years, it keeps on improving as you keep surviving from your diagnosis. So somebody who has survived for 3 years has an 80% chance of living 2 more years compared to a time point 0 where they have only 75% chance. And essentially what this does is to exclude early mortality and see that if you have already, if you're not already among the dead people in the first few years, then what is your outcome after that?
Right, but with the
Beg your pardon?
no.
No, it's not positive selection, it's just conditional. So you see, the life expectancy at birth in India is, for example, 72 years in women. But if you take 10-year-old girls, it is not 72, it is actually 79 or 80. And if you take people who have already survived up to the 70th year, then you know their chances of surviving 10 more years is actually better because for some reason they have already survived for 70 years. It's like that.
Duration of response. And that's what the famous part. Those who respond, those who achieve a particular level of response, they are going to live longer. So they are selected.
Yes, it's a selection bias, but Dr. Aggarwal is absolutely right that you know this is applicable not at time point 0, this is applicable at time point 3 years.
2 years and 3 years.
2 years, 3 years, 5 years, when the person will ask, now that I've already survived for 4 years, what is my subsequent chance of survival?
So what is interesting to look at is, if you look, just Amish 1 minute, look at this progression-free survival. You know, so look at this progression-free survival. So this is actually, you know, there is deepening of the responses. The progression-free survival is sort of increasing. So it is not declining. It's not declining.
So actually what this means is that at time point 0, there may not be a difference between immunotherapy and the other option. But having survived the first 3 years, then if you were on immunotherapy, your chances of doing well are better subsequently compared to if you were not on immunotherapy. So essentially, it is a comment about the tail of the curve. Yes.
Please, I think I'm losing out here.
Yeah, sure.
You know, between Sudeep and Ullas, I think somewhere I'm down the line. The tail of the curve tells us exactly all these things what we are discussing. What is it different that I am not able to understand? People, so people who have survived for 2 years on Nivo-Ipi combination, we all know that the tail they are going to do well. What is the extra information this is going
anybody,
to give?
please.
Detailed explanation of the tail of the curve. Because when we see it, only 20% are survival, only 20% are surviving, we get disheartened. But if we see in the other way around, at 2 years, if they are projecting only those 20% who are alive in this graph, and that is glorified if you are in those 20%, then 80% chances that third year also you will survive.
Sir, can I clarify? Just Amol. So, Doctor, so for example, if you start with 100 patients and you draw the Kaplan-Meier curve or whatever, and you say that at the end of 5 years, 50 patients were to survive, right? But if you were to draw the curve at 2 years, then you will see 80% patients are going to survive. So that is what the probability for those patients who are living at 2 years is not 50%. It has gone up to 80%.
80% of the surviving, na, sir?
Yes.
It's the same thing, sir.
No, I don't think it is just the same thing. Yeah, Sachin.
Yeah. So what the point we as a clinician want to ask, and what Dr. Raja sir also asked in the beginning, is how, when you are counseling the patient upfront, how you are going to ask him that whether he is going to fall in that 20-30% or not. Do you have any predictive marker for that?
Example, when I counsel the renal cell carcinoma advanced disease, I have a 35-year-old patient, otherwise looking good, and then I have a 65 or 70-year-old patient. I will really harp on this Ipi-Nivo, and then those long-term survival, everything comes into the play. So that's the whole data can be talked about in two different ways, such as 35 or a 65 or 70. That's the way I interpret it.
Amish, can I read the last line before Sachin? So just read the last line here, which is, said by Moitzer in the ESMO. So taken together, these results highlight the durable clinical benefits observed in Nivo-EP versus Sunitinib in patients with advanced RCC after 5 years of follow-up, and show that most patients alive or in response at 3-year landmark remain alive or in response at 5 years with Nivo-EP. So which is what you cannot predict in the beginning. So if you have a patient in response or in remission surviving at 3 years, well then he's surviving at 5 years, all of them are surviving actually. Sachin.
So, my comment on this is, the duration of response is the most attractive thing about immunotherapy, that we all agree. Now, for this particular trial, by doing this conditional overall survival, they are trying to reinforce the fact that duration of response is better. Now, the question remains is, if you do not respond, what will happen? If you do not respond at all. So, use a combination and make the patients respond to this treatment. So, that's the point of highlighting that better than using a single agent TKI, use a combination that will improve your response rate as well as you'll have a longer duration of response. Secondly, what has happened is from the first analysis, it happened that favorable group was outrightly taken as will not do well. But this trial, this is I believe is an entirely marketing thing, that even in those favorable features, if you are able to respond, then you are doing well. So that's what they have to, and the third point is, absolutely. And third thing is, now the main debate will be how will it fare against a TKI plus immunotherapy combination. Now again the idea is if you use both the immunotherapy agents, your chances of response are equally good and possibly your duration of response may be even better when you are using a dual IO combination rather than a TKI plus IO combination. So that's what they want to highlight with all this conditional survival.
But in other cancers are already failed. It looks like in CheckMate trial, where IO has a worse survival as compared to the IO.
Can I just?
Pravisha.
I'm going to try and address Amish's question without referring to any of the publications that you are referring to. Okay. Let us take the example of chronic myeloid leukemia before the TKIs came into the picture. So if at baseline it means I am a patient of CML, I will ask you what is my chance of survival. Okay. So what will you answer?
Busulfan 2.5 years, hydroxyurea 5 years, interferon 7 years.
Right. Now I have a CML patient who has a HLA match sibling. What is my chance of survival? So that is because the time interval is baseline versus 1 year when I have got the HLA match. Now I am a CML patient who has got the BMT. I have passed through the first 80 days and I have not developed graft versus host disease. What is my chance of survival? So do you see the different time frames and the different circumstances will change the discussion about the survival, whether the patient is the same, right, but the whole discussion of the survival is changed.
I answered your 95% of the questions correctly without knowing what is the concept of conditional survival. That is what I am trying to say, sir.
So taking this further, what all these trials are trying to do, the thing I mentioned that maybe they are trying to increase the level. But at the same time, at a biological level, there are some intervention done to select out a group of patients who are going to do well based on certain parameters which we are supposed to know, like A, B, C, D. If you see the melanoma trials, at 2 years they stopped the trial.
Right. That's what I said.
Done well even after stopping the therapy for 1 more year. So this probability of doing well is actually a principle of selecting out a unique subgroup of patients by modulating their immune system, I guess. So the label can change based on what time frame you're looking at.
Right. So I think, these are models which are being created. So the label has not changed. So let's be very clear. So, I don't know whether you're interested in changing the label or not on this data, but at the moment the label still says intermediate risk and high risk. So it is an option available to us, whether you want to switch from a TKI versus an ICI versus 2 ICIs, the choice is yours. And I think Amol did make a point, but that's a cross-trial comparison between ICI and TKIs versus, Cabo and Nivo, et cetera, which seem to be doing little better, but then though that is a cross-trial comparison. You have a similar kind of complete response rates and response rates in untreated patients. So I think that was the whole discussion on the conditional survival, because Nivo-Ipi is a protocol available for us and for patients with advanced disease. And similar, studies have been shown by other authors to look at the conditional survival. And as you can see here, the 1 year PFS for Nivolumab group after living, for 0.5 or 0.75 years were 19%. So, with the difference is that with these drugs like immune checkpoint inhibitors, you actually continue to do better. So it is maintained, whether it is Nivo-Ipi or whether it is, Nivo with an immune checkpoint inhibitor. So I think that is the point I think the side effects, anybody wants to touch on the side effects with Nivo-Ipi? Ashish, you are doing that trial. So, are you okay with that as compared to ICI versus, TKI and TKI?
Yes, IO combination in this dosing which we are using is fairly well tolerated.
Is well tolerated. And anybody else has an experience? I haven't used Nivo-Ipi too much. So,
in this particular trial, whatever the fear of side effects of combination is restricted only in the induction phase.
Right.
It's only for the first 4 cycles.
Right.
After that, it's smooth.
Great. So I think that's nice to hear that the immune checkpoint inhibitor combination is not all that toxic than as compared to an ICI and TKI combination. So I think we can stop this here and then move on to the next part of the discussion.
So just one small question. So Monday morning, do I do IO plus IO? Or do I do IO plus TKI?
So you can have show of hands. So you can have show of hands. Amol, what do you think? Okay, stays in Sunday. Okay. Yeah, please.
Concern about progressive disease also. So for patients with a very high visceral disease or disease burden, do you think that IO plus TKI response rates are much superior? I think around 40 versus 60%. So on Monday, if there is a studied disease everywhere, whether IO plus IO has around, I think 25 to 30% progressive disease, whether we lose that patient.
High disease burden. And any comment there? Because that is, again, as I said, it's a cross-trial comparison. So
actually, the question which Ashish has asked is the prime reason for having this discussion. And we all together have to say that there will always be 15 to 20% of patients in each this subset what we are discussing will be very good candidates for IO plus IO combination. Now we have to identify who are those. In RCC, I think there is a lot of studies have been done, and in RCC, I think 4.5, 5 years follow-up is there. And what they have said very clearly is that low tumor load, less symptomatic patients, and in patients where you are not too much bothered about the response, in an organ damage type of situation is there. If none of these are there, you can start with IO plus IO. And in fact, there's a very amazing study going on, I think called Cosmic, and correct me if I'm wrong. In triplet they are doing, they are giving IO plus IO followed by TKI. I think that would be, then, right. So I think how I look at it is that you give Nivo plus EP in the select group of patients you have said. If the patient at the end of evaluation is doing well and has not progressed, you have hit the jackpot. And if the patient is progressing, change to TKI. And 2 patients that I have done like that, and both of them have added Cabo because Nivo and Cabo data is there, and both of them are doing fine. But just 2 patients.
Right. So I think the intermediate and the high risk, Ashish.
So I think, Amish, only one point that these are very subjective clinical parameters which we will consider. Whereas the story in RCC becomes more complicated because we do not have TMB and PDL1. It's an immune disease in general. So if we can get a flip with some sort of predictive marker, then probably we would be in a better position than just to contingent upon the clinical parameters. So yeah, I mean, it's very difficult call in the clinic.
So that is for for them to ask that. But before that, before answer your question, I wanted to ask Dr. T.
Yes.
Raja and Senthil, how would you answer Ashish Joshi's question, sir? Like, which are the patients you will select for IO plus IO and IO plus TKI?
Amish, yeah, you are the obvious already. You have already told. But if sir can go back to some of his trials, we know that there is an early, particularly in the pembrolizumab plus axitinib trial, early separation versus the CheckMate 214. There is an early crossover, and the rate of progression. Those are the things. Exactly what you said. You no other choice. But if you have a high tumor load and if you have an imminent progression, I would definitely need a TKI along with my. There is no doubt about that. Or the only proven thing about the double IO is like if you are looking at an indolent kind of a patient where there are no imminent or and then a younger patient, I want that longer proven, longer survival establishes. That's where I use. I have quite a few patients on this doublet, and just to add, they're doing very well, sir. They're tolerating.
So I think high tumor load, symptomatic patient, avoid.
It is very akin to visceral crisis and hormone.
Right, okay.
The other point is those who have sarcomatoid histology.
Agree.
The data
Absolutely.
Data is good for doublet.
Checkpoint inhibitors work well,
but the complete response rates that you get with sarcomatoid are much higher for EP-Nivo compared to
Correct.
other
So
populations. That's another area you should consider. 16% CR.
okay. So can we move on? I think we can discuss another paper on CRC. So, yeah, Vineet.
See, at this point of time, there are no biomarkers available, robust biomarkers. So what you go about is with the risk stratification. Even in the intermediate risk, if you have intermediate 1 only, they tend to behave more like a good risk patient. And it has been seen in good risk patients, you have more preponderance of the vascular endothelial growth factor blockers, which work better as compared to the immune markers. So if you have good risk 1, probably in that you can have a combination of IO plus TKI, which would do better than a IO plus IO.
Right. So I think we made that point that in the favorable risk, we have more of angiogenesis and the immune checkpoints, kind of take over when patients has more aggressive disease. So I think that's the slide to show in colorectal cancer that the incidence of MMR is to the tune of 4%. And that's what is happening, with patients who are treated with pembrolizumab. And so you see these responses happening with pembrolizumab. So I think this was the study which was done by Lens. And, you have these patients with CheckMate 142, where Nivo-Ipi was given, and for patients with MSI-High. So they had the primary endpoint of overall response as per investigator, RECIST 1.1, and the other key points. So the question was the number of patients. I think there were few patients in this. So any comments from the panel here on the endpoints and the number of patients?
Primarily, sir, it's a phase 2 data.
Right. It's kind of an ongoing study. I think they're still enrolling. Yeah.
Yes. So I think phase 2 data, N number cohort is very small. Yes, the results look pretty impressive, but whether that would translate into my clinical practice, not sure.
Not sure. So I think that is, yeah, Sachin?
So Nivolumab and Pembro both have been well established as second line in those who have high MSI. And for Pembro, there is a phase 3 data as compared to chemotherapy, which has shown a PFS benefit. So obviously on the same lines, something which is immunologically driven, instead of one IO, double IO possibly will improve our responses and the duration of response. That's the possible philosophy for trying this particular combination.
So this, yeah, right. So this study also focused on BRAF, KRAS mutation, although the numbers, as you see, are 13, 17, and 10. So there are very few patients here. So I think let's go to so this is the data there, which says, I think this is the other important slide, which tells you about the overall response rate, with a gap of almost 1.5 years. So from 60% going on to 69%. So, that is the point which these immune checkpoint inhibitors are doing, that over a period of time, patients who have stable disease, now you see here, so from 11, they've gone down to 7, and the CR rate from 3% has gone up to 6%, and the PR rate is from 53 to 56%. So, that is the advantage of these, the difference between what we were seeing before with the targeted therapy than as compared to what we are seeing with these immune checkpoint inhibitors. So, any comments from Prabhat or from, yeah.
It's meaning they continue to respond, we know, but I was also impressed by seeing this, that they continue to respond in the terms of overall response, going after 1 year, 7% convert to 13% CR. Even I didn't think, I thought response will come initially, and it is maintained, duration of response is maintained. So I am also impressed by this data, that they respond in terms of the histologically also.
So that is the difference which we are seeing with these immune checkpoint inhibitors, and the responses are sustained. And this is seen in this particular slide also, where you can see that 13.8 months and 29 months of median follow, which is the red bar. So you see there's a deepening of the tumor response over a period of time. Okay, so I think these are so the median survival in these patients is not, achieved. You can see the curve is kind of plateauing. And what they wanted to also show, I just skipped these slides, they also wanted to show the differences between, KRAS mutant and BRAF mutant and the BRAF KRAS wild type. Although, as I said, the numbers are small, so you can see the objective response rates virtually, 70, 80%, even in patients with KRAS mutation and BRAF mutation. Yeah.
If somebody knows about Keynote 177, which established pembrolizumab at first line, KRAS was the only forest plot chart which exactly touched the line of unity. And here it is saying that Nivo-Ipi still continues to respond in spite of KRAS mutation.
Yes.
Although numbers are 10, but 80% response rate is.
But Lens does admit that the numbers are small.
Yeah. But this is something little paradox between the two trials.
First thing is, in 177, though you're right that for patients who had a KRAS mutation, the point estimate was very close or on the line. But again, for the same reasons that it's a very small proportion of patients who belong to that category, I don't think we should interpret it as a negative biomarker for response to immune checkpoint inhibitor. That is number one. Number two is, if you look at the response rates for patients who had a KRAS mutation, it was somewhere around 53-54%. So, based on whatever data we have, I don't think you need to change your selection based on the presence or absence of KRAS mutation. But one place where I think a combination might be useful even in the first line would be, again, patients who have a larger tumor load. Because the responses that you get here is much, much higher compared to what you get with single agent. A kind of situation where you would think you would want to use a combination of chemo plus an immune. So I think those are some situations.
What about doing the other genes, for example, what we think about STK11 and,
Again, they are all prognostic. They are all prognostic. Again, even in lung cancer, I think the experts are there.
Right.
As much as I know, they are all prognostic. They are all negative, not negative biomarkers, negative predictive biomarkers.
If you see Keynote 048, in that head and neck also, the KRAS mutant data works.
That's why I'm saying that is prognostic.
Prognostic,
It is
yeah.
prognostic, not predictive. That's the point.
So do we use it tomorrow?
Or should we use the combination in KRAS?
Don't take it to Monday.
Right. So I think just before. So I think there is also this discussion which is happening that MSI-H tumors are not created equal. MSH26 associated with higher TMB. I don't know whether there's implication on the treatment, but then, that's the kind of data which perhaps is evolving. And so the TMB cutoffs are also important here, but then I'll not go into the detail of this because it's not on TMB. So I think as per the NCCN guidelines, as you see here, Nivo-Ipi is recommended even if, patient is eligible for chemo. So that is what the NCCN guideline says here. So we have few more minutes. We can go on to the NSCLC and tumor mutation burden. And I mean, these were the earliest studies which, showed the efficacy of Nivo in NSCLC. And this is the study design. So this is a little, interesting study where they recruited perhaps in two parts, more than 1% PDL1 and less than 1% PDL1. And anybody wants to comment, Ashish?
It also had a component of high versus low TMB.
Yeah.
As we move down the line, the conclusion was that even irrespective of the PDL1, the combo was effective across the subgroup. But when it came to high versus low TMB, the patients with low TMB did not get benefit. So this is probably one trial where TMB triumphs over PDL1 as far as the lung cancer is concerned.
Yeah, so irrespective of PDL1 status, if the patient had high TMB more than 10, so these patients benefited from Nivo-Ipi. So why did they choose the 10 mutations per megabase? So I think the responses started plateauing at 9 to 10 mutations per megabase, and that's why they chose this particular cutoff in this study done by Hellman et al. And so the number of patients were smaller as they were selecting by TMB because they wanted to. There were only TMB evaluable patients of 1,004, and only 71% patients had, PDL1 more than 1%, and 29% had less than 1%. So the numbers really, got small when it came to analyzing the data on high TMB patients. So I'll just skip this. So this is the progression-free survival and duration of response in patients who had high TMB. So you can see the curves, those separating, quite late when you look at Nivo-Ipi versus chemo, but then the hazard ratio and the p-values are significant in favor of Nivo-Ipi for patients with high TMB. And that's the point I think Sachin was making, that even if the PDL1 expression was less than 1% in this group of patients, so Nivo-Ipi, see the curves, separating almost as good as patients who had PDL1 more than 1%. And again, irrespective of the subtype, squamous and non-squamous. So any comments from Dr. Pushkar or anybody here, please? So do you agree with this? I mean, would you like to do TMB now in your patients? Although this is an old data of 2018.
The issue is there is definitely benefit with higher TMB. So I would always like to do TMB before initiating on this treatment.
Say that again, please.
Before initiating on this treatment, I would definitely like to have a TMB.
Right. So you like to do the TMB. Ashish?
So here we have four scenarios. We have a high TMB where you use mono IO versus combo IO. And you've got low TMB where you use mono IO versus combo IO. In a low TMB, both groups do not work. Where the CT, the response rates, the PFS, both chemo scores over the IO. But in a patient with a high TMB and a high disease burden, then the combo IO has shown a beautiful response rates, and the hazard ratio is impressive across in terms of PFS, OS, as well as the response rate. So I think that group of patients with a high TMB and a high disease burden, Nivo-Ipi could be one combination which could be used.
So I think the problem in this study was the primary endpoint was PFS. So the endpoint was actually not OS here. So when they went on to OS, so it really didn't stand the test of time. Yeah, Mish. So I think let me say this. This is the study here. The BMS submitted the following exploratory OS data to the FDA for a TMB more than 10. You see the OS 23 months versus 16 months for chemo, and TMB less than 10, 16 months versus 12 months. So the hazard ratio for both the subgroups is 0.77 and 0.78. So that is why the study did not kind of has been, taken off, and the approvals have not been given, to in all this category. Dr. Kumar.
So I think this is one of those learnings for biomarker or the treatment, that how the concept works.
Yeah.
So here the concept is TMB, and you give it as a tumor agnostic biomarker. So looks like TMB has not stood until now. We need to wait for some more time, that it is really tumor agnostic in every place. And that's why it is one of the reasons it has not picked up in lung cancer. This is not the one example. Durvalumab, when they want to develop, they did again went for TMB and scoring it and then developing it. It again failed there as far as the lung cancer is concerned. So this is a good example that we need to be a bit careful about, and seeing that concept gets has a validation in multiple situations and multiple ways, then we know, it works.
And then we have alternatives, Say, this one works, for example, when the PDL1 is more than 50%. So as you rightly said, look at the Durvalumab and the combination trial. So it actually failed. So the high TMB is not the sacrosanct for using immune checkpoint inhibitors.
Totally agree with what Kumar said. Also, in the other trials of Keynote 189 and Keynote 2442, when they analyzed BTMB, it didn't work.
Correct.
Then how do they analyze the TMB, blood or tissue? What are the cutoff values? A lot of
So this is
no.
Just addition that in case if you do it, be careful that for a TMB to be judged, what is the output you are getting from the report. So if you take 10 gene, 50 gene panel, you are not getting enough output. You require at least 1 megabase or at least 0.8 megabase of output from the single test, what you get the panel to do it. And for that, you usually require some 200 odd genes, usually gives
even more, right?
240 something.
300, 400 gene
Something,
comprehensive gene panel to be done.
Remember that.
So I think the data is available for this study also, CheckMate 848, where they are comparing, the tumor TMB with the blood TMB, and I think the findings are concordant there. So, but I think, as has been rightly said, so TMB alone per se is not the criteria for selecting patients for Nivo-Ipi at this point in time. Unless you have, if you look at the approval here, I think I have the 1 minute. Yeah. So, when they say 1 to 14, so 1 to 49%, look at the Nivo-Ipi in certain circumstances. So they haven't sort of, clarified there. This category 1 though, in the NCCN guidelines, in adenocarcinoma or even in squamous cell carcinoma. So that circumstances possibly is, high TMB.
Can I add, sir?
Yeah.
So again, this gets highlighted here. NCCN says pembrolizumab, more than 1% PDL1 is a category 1. So be careful. Again, we need to be a bit careful about it. What NCCN says, ask almost anyone treating lung cancer. If you have 10%,
right.
PDL1, they
No,
won't.
we're just talking about that. This is what is available in the literature on the NCCN guidelines. It's available in certain circumstances which have possibly not been defined here. So I think we're running out of time, and with this, I thank all the panelists for this discussion and everybody for participating. Thank you very much.
बनावली सर, ये मंडे मॉर्निंग का कौन पूछ रहा था सर, बताएंगे?
So Monday morning for Tata people is very simple. Tomorrow Tata is closed because of Buddha Purnima, so we are happy. We don't have to talk. Yeah. So thank you, first of all, thank you Amish and Purvish for this thing. And I think after this is the first one I'm attending, your Oncology Beyond the Obvious. After hearing this, I think we should stop our didactic lecture meetings that we have, which has no meaning. If at all, I think these are the interactive meetings look much better than. So thank you, Amish, for starting this. And again, I think, when I was a resident, Purvish and we were co-residents, I used to hate APMLs, if APML came, because the platelet pheresis machine was in our department, we had to do the platelet pheresis. It used to take 3.5 for one. So if there's 2-3 patients there, the whole night I used to sit on this thing. And the same disease with chemotherapy, and even bone marrow transplant. When I was resident in 89, the Memorial Sloan Kettering outcome was around 45% with all, including chemotherapy and BMT, and with so much supportive care and so much efforts that were required. The same disease today, we are waiting for a patient of APML to come, because with arsenic and atra and arsenic, we don't even require them to be admitted on oral. No, okay. So, the same disease now, our residents wait. If we don't have a APML patient for 1 or 2 weeks, what happened? Because now with oral therapy, with outpatient-based therapy, we have 98 and 96% outcomes, and even in Tata and even in India, I would say, it's not the West only. So we also have that type of this thing. So things have changed. The same now with AML. AML, for example, if you see again, Dr. Naval Dower's data of FLT3 positive ALLs, 80-year-old, and the older patients with decitabine, FLT3 inhibitor, sorafenib or any of those, and venetoclax, again 80% 2-year survival without transplant, without this thing. So things are changing, and I think the same thing is reflecting here now, that we are going away from chemotherapy. Chemotherapy alone, we used to tell that alone is not going to cure most of our cancers, and I think that is proving true, and especially the disseminated cancers that we have talked today. So, or the advanced, what we say. So definitely things are changing, and we are going away from chemotherapy and towards this now immunotherapy and the TKIs that we are using. And again, like Sudeep told, we are old people. I'm old. I'm older than him, so I can tell you that. I don't know how many of you all know Skipper's Law. The younger ones, I'm telling, not here. Skipper's Law. Anyone know Skipper's Law? No, you are not. And you are advanced one, so you are not younger. You are advanced one. So, it's very important, because today a lot of discussion happened on conditional, this thing. This is typical of Skipper's Law that we were told. And, when this all thing, the first thing that came to the mind was Skipper's Law, because Skipper's Law states that you always, by giving chemotherapy, you are always going to kill a fraction of your cancer cells. So if you have 10 raised to the power of 5, it will go to, and usually the chemotherapy causes only 1 or 2 log kill. So if you say 10 raised to 5, it will come to 10 raised to 4. That means from 1,000,000 cells, it will come to 100,000 cells. But the same after another chemotherapy, from 1 log kill, from 100,000 cells to say 10,000 cells. So what is happening here is that the first time you kill, it's like 9 lakh cells, second time only 90,000 cells. So what it says is that by giving chemotherapy, you are only going to kill fraction of the cells, and all the cells can never be killed. And that is why the chemotherapy, if you see the log, it goes down and down and down, and you never get that flattening, which now is happening with the immunotherapy. So that is what has changed the thing. With immunotherapy now we are seeing this, because we are not using chemotherapy, and we are using the immunotherapy that we say. And that again is not something new, because being a pediatrician also, in childhood ALL, for example, after you are okay for 2-3 years, or maybe up to 5 years, we always say, after that it's a flat line. And we used to always feel that we are by giving the maintenance therapy, we are killing the cells which are coming back in circulation, but now we know it's wrong. And what we are doing is the immunotherapy. So both 6-MP and methotrexate that we use as maintenance is a prime example of immunotherapy, and that is keeping that line flat. And that's exactly what now we are seeing with this immunotherapy, where if you have a flat line at say 3 years, you are straight. And somebody mentioned about it, I think it's in Hodgkin's disease, where they found that if you have a PR, a complete remission with immunotherapy, if you can stop at 2 years and that line remains, you don't have to give maintenance or keep on giving the immunotherapy also. So again, it says that immunotherapy works differently than chemotherapy, and that is why when in someone that it works, that gives you the flat line. If it doesn't work, it will keep on going down there. But that 15% where it works, it will keep it same, and that's what we have seen again here. Now again, giving, the Ipi plus Nivolumab versus in TMB, for example, we talked last. Again, we are talking about something, we are comparing apples and oranges, because the immunity or the immune therapy we are talking is same, but immunity is along with that, there's a tumor microenvironment. And the microenvironment is different in different tumors. The microenvironment in the RCC is much different and is more anti-angiogenic as compared to the microenvironment in lung cancer, where there's more inflammation and all the others. So it's different, and that's why something that works in one tumor may not be working in the other. So lot of things, lot of biology to learn, lot of things to learn how to use these therapies that we are using. And the concept of, it doesn't work in favorable, it's not that it doesn't work, it is not superior, because it's still giving you good outcomes. 63% is not bad, so it's giving you good, but it doesn't improve it further, because maybe you need something more than just immunotherapy for those patients compared to the high risk patient where you have to give or where it works better, but again that can also be improved. We should not be happy with that 30% or 40%, we can even do better. So I think it was fun, and I think we learned a lot, especially enjoyed interacting, there's so much good interaction.